So I just want to start, this is very Providence, culturally speaking, this is a very Providence thing to do, but I think it fits really nicely with where we're at in terms of this, I would call it a sweeping change through the long-term care home, particularly starting at Comox, but it'll be everywhere. So this is a reflection I wanted to anchor us in. And it's a simple quote: some old-fashioned things like fresh air and sunshine are hard to beat. And the reason that I wanted to start us with this is that this is the rendering, this was in Mark's talk as well, but this is the rendering that I have been working with as a person who's been attached to this program for the last few months. And this is, of course, it's just a cartoon drawing, and I've had a lot of inspiration that I've drawn out of this and what it's going to mean in terms of the people living in this building and the different opportunities and the way we're going to think about staff and how staff work in these homes. So this is the inspiration I've been drawing on. And it wasn't until 2 days ago, Mark had mentioned, that I had the chance to actually go to the site. These pictures are old, as Mark mentioned, they're about 2 weeks old now. And I had the privilege of standing on the ground floor level and just got a sense of the magnitude. It's a terrifically large space. And the reason that's so meaningful and important to me is thinking about some good old fashioned things like fresh air and sunshine are some of the greatest pieces of life's pleasures. And I have so much optimism and frankly hope for the way that people are going to experience a better quality of life in this new environment. And that's partly because the courtyard, though it's clear in the cartoon rendering that it will be a beautiful space, the courtyard, I think, is much bigger than I had imagined. And I think it's going to be a truly meaningful interactive space for residents, for their family members, for staff, and for all of the people who are involved in what this is going to be a community. It's not just a single home. So I'm hoping to do three things. The first thing is that Mark had touched on the social relational model, and that's the model, the name of the model that we're calling. We're calling it Home for Us Too, so you'll use me here both terms. And then I'm going to tell us where we're at in terms of designing this new model, including talking about the pilot. I think my background is nursing, as was noted in the introduction, and I'm empathetic to knowing how this is the way we do things, and this is the way it's always been, and it's tough to change these things. And the model that we're implementing at the Views and into our homes in other sites, it's vastly different, and all healthcare professionals and providers working in these environments will be affected by this. So the pilot is the first part of what I would call a sweeping change in these homes. And I'll talk a little bit about the different considerations that we're giving for that. And then the third thing I just want to touch on, which I think is a really interesting and frankly, it's a privileged part of being with this project as a person who also has an interest in academics. I'm going to tell you about how we're evaluating the impact. We have a very special partnership with research scientists who are actually looking to see if we're doing this and we're making any actual impact. So I think that's a unique feature of this project. So I just want to start by talking about the social relational model of care. And Mark touched on the origins of this. We're drawing on pre-existing facts about how people live a life well lived. And I generally tend to think of this as novel because I think it's vastly different from what we're currently doing. But on the other hand, that's a bit of a funny tension for me because this is frankly just getting people to live normal lives. The lives that we all live currently, we're trying to translate that into an environment where people live with healthcare supports and with community supports. And it's hard to imagine that we haven't been able to do this well yet. But as I said, I'm feeling very optimistic for how we're going to go forward. So the social relational model and the model we're calling Home for Us is grounded in these three principles. And the ideas come from they're heavily rooted in the idea that each person has human dignity, which is foundational to the way we understand how everyone exists in the world at Providence Healthcare. And I'm imagining that's true for you and the organizations you work with as well. And that means that choice and the idea of being able to make your day and do the routine and the rhythm of the day and the way that you do it now, you get to make a lot of decisions about that. And that's one of the most fundamental drivers of these three principles. So the first principle is emotional connections matter most. And there's a quote here: people won't remember what you said or did, but they will remember the way you made them feel. Emotional connections refers to all the people working and living in the community. So that's not just the emotional connections that exist between the residents and the staff in the building, but it's the connections between staff and it's the connections between residents. And the entire community is designed to grow and flourish emotional connections between the people living in the community. They're sincere, they're authentic, and they're fulfilling. And that's for everybody who's in the community. The second thing, and this is where we're really seeing choice come through, is residents direct each moment. Time is not measured by a clock, but by moments. And in the institutional environment, the rhythms and patterns of the day are usually set by the needs of the organization and the institution. For example, when the kitchen is going to have its meals ready is probably when breakfast is going to be, and lunch is going to be, and when dinner is going to be. And none of us, for the most part, are living in lives that have that kind of external structure. We usually eat when we're hungry. To Mark's Saturday morning experience, he eats around noon his first meal, and that's after watching football. And I think most of us would relate to that we have choice in the most mundane, if you will, experiences of our day-to-day lives. And the idea is that we do a really good job, exceptional job actually, at making sure that folks living in our homes get to make choices about what they do on a moment-to-moment basis. And of course, that's not true in the institutional structure that most homes are designed in. And the third thing, which I think relates to both the first and the second principle, but it's home is not a place, it's a feeling. Home feels friendly, relaxing, secure, and familiar. So partly, I think this relates to the fact that we get a new building. It's a privilege to have a new building, but we're going to put this pilot and this model into older homes as well. And that means that it is partly related to the beauty of the space and that terrific courtyard we're going to have access to, but it's more than that. The idea that home feels friendly, relaxing, secure, and familiar means that we give careful consideration to what's going into the home. And one of the, I guess, mistakes that I think I made recently, some of you may know I was at Central City Lodge and we had received a large amount of money to make a capital purchase. And then we brought all the staff together and we put our heads to decide how we wanted to spend that money. And it was tables in the dining space. And then we purchased hospitality grade tables, and they look like hospitality grade tables. They look like a restaurant. And I think now, knowing so much more about home for us and where we actually ought to head, I think that that might have been a mistake. We invested into beautiful furnishing, and it is beautiful, but it's not what you'd have in your home. It's what you'd see in a restaurant or in a dining experience. And that's what we're trying to get away from. And we're moving towards just having a normal life. And you don't have hospitality like style hotel furniture in your home most of the time. So Mark points to this, but this is one of the pieces that I'm directly drawing from just because it helps us give specific examples of how different we're going to create the model, as well as in the pilot, we're starting to see how we're actually building out the pilot and thinking about what we need to do. But this is the Be Advice, which is the De Hooyweg, their company, I guess. It's the consulting company that has come from the success in the Netherlands. And they have created these 4 domains. One of them is the individual, of course, the home, which is, I'll use the language of households to talk a bit more about when we're talking about individuals within groups. The living environment, so the space that we're in, and then the organization and the process. And here's where Mark had briefly touched on some of the HR work we had to do, which to this point has actually been fairly extensive in terms of trying to get our organization to actually adapt and adopt a different way of moving, which has involved job description changes, which I'll talk a bit more about. And then within these 4 ways of thinking, so we're always looking at these 4 lenses, we then consider 7 aspects of what we would probably all agree constitutes a meaningful quality of life. So favorable surroundings, lifestyle, and I'm going to come back to that in a second. Health, meaning health is still, our health and care experiences are still excellent. We don't compromise on the quality of nursing or expert care, as Mark pointed out. Of course, we still have a physician, and there's just a different way of seeing a physician in the new model. But the health and the care experience is still excellent. Life's pleasures and meaning of life, formal and informal networks, organization, and then social inclusion and emancipation. So taking this from the Hooyweg experience and then translating this into the Providence Living and Providence Healthcare experience, here is how we've applied this within the context that we're actually working. So going to favorable surroundings first, this is actually drawing from many of the points that were brought up in speakers before me, but residents have familiar surroundings to reduce confusion, agitation, frustration, anger, and desire to leave the household. So that familiarity in part relates to being intentional about what goes into the spaces. And that includes, for example, instead of having restaurant style furnishings, you have furnishings that you'd see in a home. We work, our team, we're fortunate, we've got very experienced specialists who assist us with both the creation of the pilot as well as design considerations for the new build. And there's a designer we work with who works specifically in designing dementia-friendly spaces. And what she pays attention to is well, from a theory perspective, it's just terrifically interesting, but it's very compelling to think about what we think about in terms of anchoring and locating ourselves in a particular room. So for example, in a dining space or in an eating area, you need to see a fridge. And if you're a person that is not easily oriented to a space, you need to see things that are familiar to you so that you know what kind of space you're in. It helps you be oriented in a different space or in a space that you may know, but you may have a hard time remembering. Things like the living environments, like our relaxing spaces, for example, they have blankets, and that's not currently in place in a lot of the homes. But in the new way of thinking about the pilot, it's a small household, as Mark mentioned, and the details that we see in our own home, like throw pillows and like throw blankets, which are common features on a normal life and on a couch that you probably have at home, are also built into the design because that helps people realize that the space they're in is a safe space, it's familiar, and it's favorable based on what we would all say is just a normal life. I just want to get a little bit into lifestyle because Mark talked about it. Lifestyle is the idea of who we are. So as an individual, I think that we can come to know people through different ways, and there's a lot of strategies we can learn about a residence. And actually, I think for the most part, we do this pretty well. In our existing homes, it's very evident to me that the staff are in genuine emotional connections and relationships with people, and actually, for the most part, can tell a fairly detailed story about each resident that lives there. Of course, we can do that better, but I think actually we do this fairly well. Lifestyle is another level, though. Lifestyle is thinking about what unites people in their similarities and what might build a community. I'm not sure that the Netherlands model is going to work with us. And as Mark said, it doesn't feel very Canadian, and I agree with that. I think we're a diverse group of people, and we like that. That's one of our strengths. And I think it would be hard to decide that people who live in the community would be united by, say, for example, a mid-century modern style, which seems to be one of the types of things that is anchored in the Netherlands model. So, for example, classic style versus rural style. I'm not sure we could do that. But our team has gone back and forth a lot about what we could do that does unite people. And one of the things that we haven't made a decision on, but is an idea, early birds and night owls. That could be a way that would unite a group of people, that would set a rhythm and a pattern to the day that is actually based on what you like as a person, as an individual. I'm a night owl, so I would join the night owls. I wouldn't do well in an early bird home. And I have to be honest, if I lived in an early bird home, I'd never make it to breakfast, and you probably wouldn't see me at lunch. And then my rhythms would be entirely disconnected with what's actually going on in the household. And as Mark said, and I will get to it again, we're going to have our food prepared in the household. So I'd be late for every meal. I'd never make it. And I certainly wouldn't be happy eating dinner at 5. It just doesn't fit with my normal patterns. Health is not compromised. We have a very robust plan to keep our clinical care excellent. And in the new build, but also in the pilot, we'll have very careful detail to ensuring we have exceptional quality. We don't compromise there. Life's pleasures and meanings of life. There was a really good question. I can't remember who it was posed to. It was maybe to Mark. And it was about how so with our community center being in a centralized space, those are what we would think of as maybe formal or structured or programmed, therapeutic programming in terms of that activity experience. How do you then get it and translate it into your small household? Well, the answer is we updated the job description so that everybody who's working in the home has a responsibility to think about life's pleasures and those informal moments of making life meaningful. So all of the things that we do that make our lives meaningful, for example, doing a puzzle, playing a video game, reading a book, having chat, connecting with someone over, in my case, birds. I like birding. If you want to talk to me about birding, staff would know about that. And each of us now has a responsibility to think about a way to connect with someone and put emphasis on life's pleasures and meaning of life in our day-to-day work. Of course, we have the typical job responsibilities. For instance, as a nurse by background, you would think in a household, I would be somebody who'd be delivering medications. I likely wouldn't be doing the terminal cleaning of a room that needs to be properly cleaned. It's not on my skill set. But what I would be expected to do is realize that I walk into a home, that I'm part of the household experience, and that I have a responsibility to create a therapeutic, meaningful environment. And if I see somebody who looks like they may be interested in doing something like an activity to table, I would be able to then, within my job description and what the expectations are of me, to sit down and have that meaningful engagement. So activities are built into the households in a way that creates both informal and formal experiences. And that's because we updated the job descriptions. This touches a little bit on the formal and informal networks, but a lot of what Mark pointed to, including the idea of a daycare being on site, and even the idea of a bistro. The view was beautiful. We were actually able to see the patio and stand on the patio and look out upon it. It means that where we have homes now that you couldn't imagine as a community member experiencing much social engagement or community experience, for example, at Central City, but you could in this environment because the bistro has a license, liquor license, as Mark had mentioned, or will, and it's a beautiful space. So you could imagine going to visit your loved one there, or even being in the neighborhood or being a staff member, and you might go there for drinks or to connect with a friend after work. It's a beautiful space, and that's the idea of being networked. It's an intergenerational idea, and it truly is a meaningful, normal space that you would expect to see in a community where you live now. And then organization, and then social inclusion and emancipation. I'm going to kind of collapse these because I think they're related. So in terms of the organization, we've given a lot of care to the overall change management, and I'll show you the management structure that we created to this. And we have staged out the pilot to ensure that we spend a lot of time on the curriculum, for example. People need to understand what these 3 guiding principles are and how they're going to be doing things differently in their work life. And some of them needed practical support. For example, everybody has some cooking responsibilities now, and I'm not a person that you want cooking for you. So there are some things that we need to think about from an organization and process perspective to make sure that staff had the right skills and supports to be able to actually do what is expected from them in the home. And then the idea ultimately culminates at the idea of social inclusion and emancipation, because life has meaning in a way that it may not have had before. There's less boredom because everybody is paying attention to the rhythms and flows of the day. You have more personal choice because the entire home is crafted around who lives in the home, who you are as an individual, what matters to you, what you care about, but then also what matters to us as a community of people. And in a 12-bed household, that's a really different experience in terms of eating together, for example, or watching a movie, making a choice about what movie you want, compared to the home where my office is currently, where 75 people use the shared space and 75 people potentially be watching the movie together. So your ability to input into what movie you want to watch is obviously going to be vastly different when it's a 12 persons living in a home compared to, say, 75 using a common space. So what is a normal life, and how does social relational model support a meaningful life? The idea here is much, much more than the actual physical space that we're designing. So here's the rendering of what the kitchen space is going to look like. And Mark talked about some of the history there and how we were able to get it opened up so that a resident can now go behind the eating preparation area, whereas perhaps they weren't able to before. And this is, I think, where I'd like to talk about the pilot. Mark had talked about the community as a whole, and to avoid a lot of overlap there and go into a lot of the details about the community space and the on-site daycare and the adult day program, I think this is where I'll talk a little bit more about what we did with the pilot. So when you're looking at this picture, what you're seeing is a staff member, and I'll just point out they're wearing normal clothes. So this is actually up for discussion. The group from the Netherlands highly recommends that folks who come to work in our homes wear clothes that they would wear in normal life, because that creates a normal community. I'm not sure in the post-COVID era how staff are going to take to that. That's up for discussion. But that is in the rendering, and I think it's intentional. And then there's not a lot of people in this because this is a 12-bed home. So this is the space where you would see it's a large space, a large table, I mean. And in that table, there's obviously it's an accessible space and people are able to pull up to it. There's food on the table, which means that we're thinking about food being pretty available to people. And in fact, when the pilot was first created, curriculum was a big focus because we're starting to think about culture change. But we're also starting to think about getting people ready to do things like think about food, think about activities, think about social planning, think about visits, and starting to think about things that, for example, they may not have any connection to in terms of their job. So for example, everybody's job descriptions have been overlapped in a big way. So people now have to think about not only is the rhythm of the day and the pleasures of life and all of these things are being met, but who's going to clean, who's going to do laundry, and how are we going to do lunch? So I liked Mark's description of this, that it's much more like people living in homes, and then we're community-based support workers who are going into the home and providing home support, which of course is very different from what we currently have in our homes, where the residents go to us in a sense. They go down to a space and the kitchen comes out using industrial equipment and meals are served and people are fed. And that's the language I think we would say. But that's not what's happening here. People are eating, which is what we do in normal life. And people who need assistance to eat, we'll help them, obviously, because we don't compromise on the care. But the idea here is that everybody's part of a household and we're all centering around the household. Just thinking about that 12-bed space, we're using the word household to describe 12 beds. We're using a duplex to describe 2, and we're using the word neighborhood to describe 4. And this is relevant actually because when we were thinking about not just the job description, but how many people do we need to staff? We were thinking about, okay, so what would we need on a night shift? for a duplex, for example, and how many people a neighborhood, for example, would be a reasonable workload for an LPN, for example. So we did need to put some language to the way that these households, duplexes, and neighborhoods are actually interacting, and then generally refer to the entire home as the community. So every piece of what we ask people to do when they come to work is different, which is why stage one started with a curriculum focus. We're trying to deinstitutionalize our language. So instead of feeding and instead of mobilizing, it's just walking and eating. Instead of toileting, it's going to the washroom. So these are person-centered pieces of, or examples of language that we ought to have been using this entire time, but we just don't, and we haven't. We've been institutionalized, and it's just sort of the way that it's been. But that was part of the stage one pilot as well. Stage two got more challenging. Stage two, the folks who are in the pilot home are now helping to make food. So they were involved in the assembly of a meal and then the service, if you will, of the meal. So helping set a table and have everybody enjoy a nice, pleasant eating experience. And by stage three, we expect we'll have changed the staffing ratios, and then we will actually be asking people to do much more in terms of food preparation. So that will include dinners, making dinner, cleaning up after dinner. In one of our pilot households, we were able to put a laundry machine in. So the staff will now be doing personal laundry for the residents. And the residents, if they want, they could even participate in some of the food preparation activities or some of the light housekeeping if they want. They don't have to if they don't want to. But this is entirely about choice and meaning making. So if that's something that somebody enjoys, which that would actually be me. I love organization. I love tinkering around and making things look nice. I would draw a lot of personal satisfaction, and do actually, from cleaning and tidying a space. But again, not an option right now. In the traditional homes that we work in, for the most part, like in my home where my office is, we have the industrial carts with the big yellow bags that go through. And as Mark said, we don't even have nursing stations in the new homes. So the new households have medication cupboards where we'll have residents' medication stored, but it's vastly different from having an entire swath of your home dedicated to nursing, which is where we know most staff cluster, and they enjoy that relationship with each other, but it can be alienating and isolating from residents. To that end, I do want to say that this model is so vastly different that I think one of the challenges that we are going to have in the pilot, come 2 weeks from now, the pilot is currently a 20-bed space. And in order to make this as close as possible, we will be putting up a wall, and then we will have 2 10-bed homes. People are practicing and learning. So the fact that we'll have a lower number of people in each household probably going to be beneficial for us for the next year until we move in, because the new homes, of course, will be the households are 12. But one of the things that we're worried about is some senses of grief, loss, and we're going to need to mark some closure, because as I said at the beginning, I think one of the things that we do well is form a genuine emotional connections with people. And I'm already hearing some sadness that's going to come from staff who are now going to be working instead of on Mountain View 2, which is where our pilot is, but it will be working on Astor, which is the name of a 10-bed household. And of course, they can go and visit Yarrow, which is the other name of the household, but that's not going to be the core group of people that they're working with anymore. So one of the things that we're thinking about from a change management piece is how do we support staff, residents, and families to mark and honor the relationships that they have, and then to respectfully close them off, I suppose, in a way that allows them to form new relationships in a different way. So there's some grief and loss with this pilot and the model going forward, but ultimately what we've learned from other people's experiences is that everybody's life gets better. The residents' quality of life gets better, the staff's their meaning making in life, and their life at work feels better. Everybody feels happier overall. So this is the direction that we want to head. So implementing the model and evaluating the impact, we have, recognizing the massive system change here, we do have a very, we have a large team and a lot of organization behind this, including a project manager. And these, I can share these slides if anybody would like this. We're very open and forthcoming. This has become a project I'm very passionate about. So any work that I've done to this point, hopefully Mark doesn't counteract this, but I do think that we should share this and share this work. I've done a lot of work, particularly on the job descriptions and working with HEU, and I would really like to share that for anybody that wants it. So here's the operational framework, starting down at the bottom there with education and training, which was the essential critical part of the stage one part of the pilot. Policies and procedures, we use the language of standards to refer to policies, procedures, guidelines, that whole bucket. They all had to be adapted to make sure that we were able to capture the Home for Us principles, these three guiding principles, into the way that we work. Developing the standards for Home for Us and the sustainability plan, the food experience, hobbies and interests, clinical care, and favorable environments. And then underpinning this, we've got these four pillars, which is communication, change management, quality and process improvement, the staffing model, and outcomes and evaluations. And I just want to go back to the staffing model because I was getting a few questions about it over at lunch. So the four job descriptions that Mark had said three, it's actually four. And the fourth one, which actually came before this last three that we had success getting approved, was the first one we actually created was called the household mentor. And the household mentor is the idea that we have somebody who's working in the home, who's part of the education, training, development portion of learning how to work in this different way, somebody who gets this concept like this and is able to be in the moment giving real-time feedback or real-time coaching to the staff who are working there. We did go with the language of household mentor because this is probably a peer, it's probably an HEU member, we would think. And so we had to be sensitive that this isn't a person who's doing performance management or doing any supervising, but what they are doing is demonstrating it. And I think one of the things that's probably the trickiest at all levels, even if I'm trying my hardest, I'll still slip on institutional language, for example. So the household mentor is somebody that catches us and say, it's not feeding, it's just eating. We don't call it toileting, it's just going to the washroom. So that would be somebody who would be giving us that in the moment feedback, and it's the household mentor. The second job description that we adapted was traditionally we think the care aide, and it's now the household care aide. And the reason we changed that is partly because, of course, we still need the specialist. We do not compromise on the care of the residents in the home. So we still need a care aide doing that specialist work that they're doing with residents. And they have household responsibilities, including paying attention to the rhythms and patterns of the day and adding to a flourishing, enriching community. So that job description has been updated to include things like the role of food preparation and activity planning and delivering life's pleasures, if you will, just assisting with what makes household normal, cleaning up, tidying just during general service preparation, organizing some of the events of the day. The third job description that we had is the multi-service worker. This is a person who is both cooking and cleaning. And the HEU actually had described that in their database, I guess, if you will, of job descriptions, this was closest to a community support worker. So this is a person that comes in usually in a community environment and then is able to do some light housekeeping and do some food preparations. And that's somewhat similar to the model that we have been approved for this job description, with the addition that life's pleasures are built into that. So the Home for Us principles have been weaved throughout all the job description, and that's true for the multi-service worker as well. And then the fourth one, which is actually somebody who's responsible for supporting a household, a neighborhood, so that's 4 households, is the recreation and leisure coordinator. And the reason to need this person is that, as Mark pointed out, not normal for the physiotherapist to come to your home most of the time. You go to the physiotherapist. If you are an injured person who's going to get physio or going to a chiropractor, going to any service, going to dentist, you leave your home. And in fact, it might even be an outing. You might reward yourself with a coffee on the way, because they can actually be things that add meaning to your life and give you some purpose in your day. And that's built into the new model. So we need somebody to know who's going where, who needs what, and how that's all going to come together. So that person is not only responsible for some of the more formal recreation and leisure activities within neighborhoods, but they also are aware of the different things that are going on in the broader community and help residents and family and staff to organize that together. So that person is responsible for four neighborhoods. There is one other JD that we're currently working on, which is not in the pilot at this stage, but it's coming from what Mark was quite inspired by this position in the Dehugwe tour experience, and it's called a social coach. So it's the name that we've got in draft currently, and we're not sure which profession this might actually belong to. But this is a person who has particularly good skill and expertise in supporting people who have expressions of need that the staff are finding challenging. So this is a person, there's a really good example that was a story shared with me from the Dehugwe experience. And this is a person who was asked to consult about a person who's having expressions of need. And so they were having behaviors that the staff found difficult around meal times. And the social coach came in and made some observations over time, and then made a recommendation based on their observation to the team that maybe one of the reasons why this person was having some behaviors at around meals that the staff found difficult, and I think the person would have certainly been experiencing as difficult as well, is that there were other people in the dining area, and that might have been causing some distress for the person. So the social coach put a care plan in place for the household. And I think that's a really unique shift too. We usually think about care planning on an individual level, but in this case, the social coach recommended a care plan for the household, where there was a period in advance of dinner, for example, where the dining area would be cleared and we wouldn't have a lot of stimulation or noise in the space. And that supported the resident who was having expressions of need to experience much less of these behaviors that staff found challenging. So this is a job description. We have work in progress, but we do have like a complete draft, and we'll see how that goes with the union conversations going forward. I think I'm frozen. There we go. So here's the evaluation piece that I wanted to touch on. So this is in partnership with research scientists from the CHAOS group, which is a UBC, and they have offices at Providence Healthcare. This is an extensive study that they're doing, and it is a multi-year study looking at a number of different metrics, and they're looking at populations of people all throughout this pilot, as well as the long-term home, from residents themselves, of course, the staff experiences, family experiences, and they're looking at different things using qualitative and quantitative methods. So of course, they've got their inter-eye data that they can pull from, which they are using actively, but they've also incorporated in some qualitative pieces. So for example, they have a large component of ethnographic observational data that they've collected over periods of time to try and understand how people's experiences in these homes. And we've also been doing quality of life surveys with 2 tools actually. And the goal is to try and get 9 data collection points before we move into the home, so that there's a very robust comparison from the pre-period to the post-period. So a lot of the operational burden honestly has been collecting some of the data for this study, but hopefully it's worth it in the end, and shows how important this shift is in terms of improving staff happiness, resident happiness, and family happiness in these experiences. So multiple different things being considered, and they publish various things along the way. So I just want to close on another reflection, opening on that reflection about the beautiful pleasures in life being something so simple as fresh air. We're still in the season of spring, and I just want to close with this idea that spring is a lovely reminder of how beautiful change can be. It is a change that Mark pointed out, some staff, not all, some staff are certainly feeling with some tension and some anxiety and some worry, some outward rejection, but others are very enthusiastic. And actually, just as an example, for this upcoming week in the pilot cycle, folks only needed to think about doing 2 dinners, but somebody else said, well, I'm not working and I really wanted to do lunch, so we're going to do 2 dinners and a lunch, because staff didn't want to miss out. So not everybody is feeling this as burden. Many of them are early adopters, if you will, of seeing how valuable these principles are and immediately seeing how much positive impact it's going to have for residents who are living in the home. So that's where I conclude.